Our first speaker is Dr. Xue Zhong Liu. Did I get it right? Close. From the Miller School of Medicine, Miami. Dr. Liu is the Leonard Miller Professor and Vice Chair of Research in the Department of Otolaryngology at the Miller School of Medicine. He also serves as the Director of the Center for Communication Sciences and Disorders and Miami Ontogenetic Program. He received his MD from West China University of Medical Sciences and PhD from University of Manchester. He was honored recently with the Marie and Walter Hotchkiss Chair in Otolaryngology. Dr. Liu's career has been devoted to the clinical management of deaf patients by the identification of new genes and translation of molecular advances in clinical care. His team is the world leader of human genetics in hearing loss, having discovered almost 20% of all known genes related to deafness. Today, he is going to talk about how precision medicine can be applied for genetic hearing loss. Welcome, Dr. Liu.
Wonderful introduction. So that I have to hold. Okay. Good afternoon, everyone. It's nice we come back after the lunch and the beautiful poster section and the beautiful weather outside of Omaha. So it's my great pleasure to be here today to celebrate the sixth Dr. Richard Bellucci's symposium. Richard Bellucci, probably, Molly can correct me. That's a most common name when we've been trained in operation room for ear surgery. I talked to my mentor, Tom Barkley, Fred Tanishi. That's all the ear surgery. We are very dependent on this Bellucci micro scissor, which is Dr. Bellucci invent in his life. That is one of significant contributor to our ear surgery and society. He's a giant in our field, in practice, obviously. So we will hope, through this mechanical scissor, micro scissor. Now we are moving to stage for in the ear for the gene editing scissor to cut for genetic condition, hopefully. Today, I would like to share our experience about in this era of genomic medicine, how we make effort, especially between clinicians and scientists to, to really go for next 5-10 years for gene, cell, and drug-based therapy for sensory neural hearing loss. So in the morning, we already heard a lot of excellent lecture about the genetic hearing loss in different hands. So my talk, I will really share some experience and then focus some type of hearing loss such as late onset and also adult onset hearing loss, how we combine our clinical data to move to think about gene therapy for adult stage mice and also the progressive late onset hearing loss. So this is my disclosure and ground supporting. So as we know, we talk about the hearing loss, they're congenital and severe to profound version in children and the young adultment. But now is really equal important in hearing loss in the adult and the later adult stage, as you can say from those quite recently famous study to confirm by severity and age hearing loss, that's the really burden for our society. And also, especially now is already confirmed by a multi-center study, and recently, last year, early this year, from the Hopkins group to confirm the hearing loss is a #1 risk factor for the, and also is a, can be modified factor for the early onset of cognitive decline. So I know in our otolaryngology society and also audiology society, we are trying to voice equally treat people over 50 with their hearing condition, such as supplies of hearing aids and access to cochlear implantation, and of course, very important for gene therapy. In past 30 years, we as one hand, as a genetics, like Cynthia Morton, Marley, Tang, we are working on this field for last couple of decades to identify most of the important gene. And then we profoundly, like Marley mentioned, in our practice with the patient with a sensory neural hearing loss, not just in the children, now in the move to adult subject with the hearing loss. So this is the sort of algorithm we set up when I was in Richmond, Virginia, with our mentor and Cynthia, our mentor, Dr. Walter Nancy. We are very based on the facts of genetic hearing loss. In each population, only couple of genes can account for over 50% of hearing loss in children for the severe to profound hearing loss. Now for the adult hearing loss also looks like that case, but that not that distinguished. So we still thought, now of course, we think for genetic testing, just use whole exon, whole genome sequence. But we thought, especially in some developing country, all the genetic screening still very expensive, not available for the everybody. Then the sequential screening still can play very important role. So I don't want to spend much time for this. But now, as we know, the hearing loss is an excellent example in our otology field for precision medicine. Those following item, especially, for example, I want to focus on now in genetic genomic side, we are moving from more common forms of mundane single gene disease to the most complex multi-gene or like digenic style, like we mentioned those. Okay. So we are waiting for move from evidence-based, current evidence-based practice to future like algorithm and precision medicine. Then you can say from this, my cartoons, how can we prepare for that? So certainly all the study we're doing now is prepare for that part. So challenge for genetic testing, Marnie already this morning gave a very nice outline, is really bother us because hearing loss is a very heterogeneous condition. Is over 200 genes already be cloned, but almost over 1,000 genes still waiting for being identified. That's based on current Steele and Steele Brown UK mouse data. And also, like we show, or Marnie slides show, they still have like 40 to 60% of group, whatever your patient population, we still don't know their variants in known deafness gene or new. So that still have a lot of room for us to identify new gene for hearing loss, even they are rare, and of course, clinical interpretation, technology cost, and insurance. So though I'm not to spend the time for that. So last 5-10 years, here is what I thought. How can we prepare, at least in Miami, our group? So I thought we still use a population-based sequential screening, at least in my research protocol, as well as our CNEO lab, diagnostic lab in Dr. Ticken's lab like that. So then very important to prepare for the gene therapy clinical trial, like Autofer, Akuyo organized 3-4 years ago for their natural history of a study, prospectively and retrospectively. That's FDA request before they prove any kind of gene therapy. So that's very important. Now, because we have a powerful technology for genome, we have more IT for the define the phenotype. I think it's a very exciting time for us to do that. And also, it's very important when we define, the best timing and anatomic location for therapy. That's I will give an example, especially for progressive late onset hearing loss. And also, I thought that for therapeutic way, for the auditor system, very important to develop reusable gene therapy strategies, whatever, like AAV, and especially for now, for gene editing methods, different kind. And other way is really also is very challenging now for the in-the-ear organoid. But we have a rich resource for patient with a carry with a different mutation. Then through that, we will look at the how they can differentiation to the target cell target in the ear cell for cell therapy, or to looking for further about the drug or the function study. Of course, for those therapeutic study, really we need industrial and also philanthropic support. Otherwise, only from the NIH or the DoD Foundation is not enough for that. So Miami, we are pretty much cover the South Florida and also a large of patient resources from the South America. So the hospital, including County Hospital, Jackson Memorial Hospital, is the second largest medical center in the country. So the past 20 years, when I were in Miami, do my research as well as finish my training as an ENT surgeon there, we set up a pretty nice the work flow and a different kind of a team for target genetic hearing loss. So this algorithm show some of my collaborators and the team, including my current gene function stem cell and therapeutic team, and also traditional genetic and genomic gene identification team. And also we have a pretty strong clinical research team and collaborate with a different department like Boston Pound Eye Institute, Public Health, and Aging Center. And most important, for past 20 years collaborated with Dr. Zheng Yichen's group. We are work on the therapeutic especially now focus on adult stage mice and progressive human hearing loss. I will give an example for that. So as we know from, especially from this year's ARO presidential symposium, and gene therapy to reach our auditory field already in very exciting stage. They, like the Mani mentioned, the Otofur already gave a beautiful example. AAV is work, can rescue hearing. So, but like you can say, most of research in therapy is focused on neonatal and the severe to profound stage. And so the intervention time point is to the neonatal stage in the animal, and also the hearing loss, like Otofur, as we know, is a neuropathy, but most of the patient is a severe to profound congenital hearing loss. So as we know, a mouse, adult stage mouse is similar to their in-ear mature, but it is very important, intervention in mature in-ear as a real request for application of a gene therapy to humans in many forms of genetic hearing loss, especially age-related hearing loss linked to the more mimic to dominant progressive hearing loss, like DFNA type of hearing loss, and some of recessive hearing loss. So I will use the one example to show how we work on this since a decade ago. So when we first identified this gene, by that time, next gene generation sequence just be invented. My group and the Mary King group, we finally identified this gene. I hunted for 15 years before 2013. This is why the Mary King cited in her presidential address for this very casual consulting we put together, quickly identified this tough gene called ATP gate P2RX2 gene. But this gene turned out very, in the patient family show very later on stage, and also noise suspective hearing loss, which by that time we conferred by lookout mouse model, mainly done by a Gary Hasley group and Alan Rice group in Australia and California. So after that, my group, we set up the human iPS cell from patient, from CRISPR induced type of mimic to human mutation, as well as different kind of looking in mouse, try to duplicate human phenotype. So again, like that's a thanks Cynthia introduced me to the core group of here. The Omaha's core facility for mouse. We did this very nice humanized mouse model. Already my mouse model for human disease the last 10 years down here in your university by the group. They did a fantastic work, and luckily this mouse model exactly mimic human phenotype, progressive hearing loss, and also noise-induced worsening hearing loss, I will mention in later stage. Then we thought that this will be perfect, probably example we can use, combine AAV and gene editing to say whether or not we can rescue their progressive hearing loss. And this gene is not that big, it's 4.7 kb. Then with the Dr. Chen's group in Massainier, we designed different kind of CAS9, and then because we know the hearing onset window, we try to say, different injection point to make sure, and whether they are at our stage, whether or not early intervention can get a better or more efficient rescue. So we did that. We use the two arms. One is because the early the hearing loss almost in the heterozygote mice happen in P21. Then we did two kind of injection. One is in 4 weeks, other one is 2 weeks. So as you can see from the ABR, then we show up to 6 months post-infection, the hearing be very nicely rescued, especially low, middle frequency area, which also conferred by the DPOAE. So now we already follow up this group of mice until 12 months, which is very stable hearing rescue. So the paper is under preparation. So and also DPOAE showed the up to 6 months here, and now we can show the up to 12 months. They got a very adequate improvement. And also the histology and the SEN also showed the seminars to show the editing intervention can promote a hair cell survive and maintain the hair cell integrity, as you can see from this the SEN for the injected mice. Because remember, this is a dominant heterozygote mutation. They never reach to profound hearing loss, similar to human too. So far the human mutation can be identified in different countries like Italy, China, and Japan. So, and also because some mice show the vestibular dysfunction, we also show the very nicely vestibular recovery. So this is a slides is up to 6 months. Now we got the 12 months results. So we really exciting. Now we have got already finished over 1 year the rescue work, and also we finished the adult editing on mutation-induced noise sensitivity, which also show the beautiful rescue after noise exposure to those lucky mice. So then we are very excited for this story, and hopefully we can prepare this and move to human clinical trial stage. And the second example I want to show you for recessive or progressive hearing loss. As you know, the transmembrane serine protein TMP3 is a famous recessive gene, can cause 2 types of recessive hearing loss. DFNB10 is a profound congenital profound hearing loss. DFNBA is a late onset progressive hearing loss. 20 years ago, when group identified this gene, their CI outcome is very controversial because some studies show this gene mainly expressed in the neuron spiral ganglia area, not quite in cochlea. So then half of a CI outcome is not good. But now we show is a different data. through the natural history study. And then when we decided that, we collaborated with the Nebraska Core Center for Mouse Model. We did a humanized lock-in mouse model for most common human progressive hearing loss of this gene. And the mouse model worked beautifully and show very late stage hearing loss. Not like a P2X2, I just show you from P21. This one hearing loss start like 10 months old, but it's very solid when we compare with the control group, because we use background CBA as well as the humanized sequence for that. Luckily, we did a very nice the AAV type of study, because it's a large TEMPO3 is not a large gene. We just use one injection in the adult stage, like 12 months. Then we watch it for long-term outcome. Then it's a show beautiful rescue, even you inject in adult stage. So this is gave a very encouraging. We are focused on more adult stage hearing loss, because we are technically in the mouse model, we can do the adult stage, very nice intervention. So it's not a surprise we can do in the human in different stage, but the matter is, of course, which role we will choose. For mice, right now, we are most common use a wrong window injection. Like this morning, you say we can looking for other different, probably less invasive deliver way. So that will be open the window for us. So for the TEMPO3, what do we need? This is a really touching my topic, like how clinician, including otologist, audiology, genetic counselor, and basic science scientists to work together to get that. So it's because now for the TEMPO3, we face this very critical question: what is the treatment window? So that involved with a formal natural history study. We about a couple of years ago, I organized one international consulting to work on this gene, because this is like account for 30% of recessive gene. It's not that rare in many populations. So we are leading by my audiologist and also ND PhD student. We work on the 16 centers in the world and across all the continent to get all the patients with the TEMPO3 mutation. We just got a very nice result and show the outcome of a CI, which is FDA always ask your gene therapy against the CI outcome, because the CI, as we know, we got a beautiful results. Most of everybody can be the rehabilitated by CI with a very nice speech and then get into the mainstream. So we got those data, which we are prepared for the clinical trial gene therapy for TEMPO3. So this is one example of why clinicians and scientists need to be very nicely collaboration for different forms of hearing loss, especially well-known genetic disorders such as GJB2, as well as Usher syndrome, which we are planning to do now. So then following that, because in the meantime, we are set up prepare a clinical trial for that. So that's like I say, we really need the industry to pay attention. Of course, That's why we set up this company, and also Myrtle is another small pharmaceutical company invented some money, and we got the sort of a German FDA approved, many work by Dr. Henrik Stark. Then so that means we can even start our clinical trial when I finish our final toxicity for couple of elements we want to use. Then we can start to use to do the gene therapy trial in German first. So a couple of my patients already waiting for that. For example, like two sisters from Minnesota, one already received a CI, but the younger sister said, no, she just want to hearing aids. She waiting for our Temple-3 clinical trial gene therapy. Then she can take whatever we want to inject. So hopefully that will happen in next few years. So then finally, I like a quick mention our exploration about how we depend on patient iPS cell, to try to look at whether or not we can differentiation those patient specific cell to the organoid, which is like specific in the ear cell you want. That's very important for function study, for drug screening, as well as for future cell therapy. We did that, whatever our traditional way, gene, but we use example of Usher 2A, because Usher 2A, Usher 1D, Usher 1F, like DMD gene have a very nice structure, some exon, like the Tom mentioned, you don't need. If you kick out those exon, doesn't affect the gene function, which exactly happened now for Usher 2A gene. Exon 13 contain most common Usher type 2 gene. They got a perfect structure for that. We kick out with editing exon skipping. Then we have a humanized mouse model for that. So luckily, because the rescue of eye is not great, but hearing is very encouraging. So hopefully we can work on that. And our Ear Institute and the Boston Institute, we are very focused on that to hopefully move to clinical trial soon. So that's my conclusion. I want to emphasize very consistently, the interdisciplinary team with the clinician and the research is critical for success. And so thanks for your attention. And also this year, the American Academy of Otolaryngology meeting will first hold in Miami, because now we got a huge conference center on Miami Beach. Because as you know, Miami never have a big conference center, not like Orlando or Chicago. So now we have. Now those big meetings will shift to some of it to Miami. Thank you.
We have an online question saying, have you considered trying precision animal models? Precocious animal models? Oh, sorry. So they're saying, have you considered using precocious animal models?
Yes, of course. We are, following the iCook and also gene therapy for preclinical. Use the mouse model we created.
Xue, what is? Huh? No. So I'll talk loudly. So Xue, what are the substrates for TMPRSS3? Anything known about its function? It's been around for 10 or 12 years.
No,
Maybe longer than
that's
that?
what we, yeah, our login, we are not quite touch that. It's a transmembrane domain. But we can say our new expression data is in both neuron, spiral ganglia, and the cornea. That's why through our multi-center study, 90% of patients with the TMP3 got an excellent CI outcome. But the exact function, no, recently no any group touch that. Hopefully, some of our iPS cell and the neuron organoid can help to answer that question. Yeah, you're right. No, we don't know exact function. But
In the interest of time, we have to move on. And